This case here, very interesting case. You had sent over to have a conversation about really what to do, where to refer the patient, what to do with the patient in the meantime. There's a lot to unpack here, but here's the backstory just to make sure I have it right. This patient has worn a mandibular advancement device, also called an oral appliance, specifically for sleep apnea. These mandibular advancement devices are a very good second line defense for treating sleep apnea, whether it's mild or moderate, and even severe in some cases in the form of combination therapy. These appliances can successfully treat and address sleep apnea, especially in the CPAP intolerant cohort. In other words, patients who don't want to wear their CPAPs. These are very good devices to consider. Unfortunately, you can buy the Boylan Bites over the counter. That's what this patient did. I don't think she, based on the report, ever knew that she had sleep apnea. She just got a snoring guard to stop her from snoring. So whether she had snoring or sleep apnea is irrelevant here. The point is she was wearing this device for a very, very long period of time, and it created this malocclusion. So there are a lot of studies that show side effects of mandibular advancement devices. Topic for another day, but for anybody listening to this, I just want to make sure we make the point that the literature does indicate this kind of outcome as a potential side effect of oral appliances. With that said, I attended a conference once and the presenter said something that really resonated with me, and it was the following. Somebody with a malocclusion is alive. Somebody with a perfect occlusion that had untreated sleep apnea might be dead. So the point is, this sucks as an outcome. This is treatable, but it's better than not treating sleep apnea. And as we know, sleep apnea is a very, very significant underlying comorbidity to basically every other health condition out there. If we're not sleeping well at night, we're not receiving oxygen, lots of downstream systemic sequelae occur. So let's not let the conclusion of this patient's outcome be a reason not to do the appliances. In addition, appliances that dentists make are much less likely to cause this problem. And we'll take a look at why that is and why I surmise that the reason she ended up in this position has to do with the fact that she got a Boylan bite and not a dentist fabricated mandibular advancement device. But one thing that's important to look at, I always make sure that numbers of teeth make sense when we're doing Invisalign. We want to make sense of the numbers of teeth. Sometimes we have congenitally missing teeth. Most likely in this case, the patient had her upper premolars removed as part of orthodontic care decades ago when this was a common practice. Unfortunately, this does complicate things a little bit, but we have a couple solutions that we can bring to the forefront for this patient. With that said, it's important to know that that missing tooth might play a role in the etiology of this overall treatment conundrum for the patient. So when I looked at this first, I thought to myself, what does the joint look like? Is this a problem of the maxilla? Is it a problem of the mandible, or is it both? So let's ask the question. If it's a problem of the maxilla, what's happening? When you have a mandibular advancement device, the jaw is pulled and held forward to open up the airway. That's the mechanics of the mandibular advancement device. Well, what happens is we have a retrusive force on the maxilla and a protruding force of the mandible. Those vectors of forces are held constant throughout the night against the ligaments, the muscles, the soft tissues in a position that sometimes is uncomfortable. If the dentist knows what they're doing and they create an appliance at the proper vertical and the proper protrusive dimension, those soft tissue effects are minimized. But this patient did a Boylan bite, which meant she did it in her kitchen. So she probably protruded as far as she possibly could 10 years ago. The point is, the forces on her maxilla in a retrusive manner were probably rather significant. So I'm asking myself the question, do I think, before I look at the CAT scan, do I think it's protrusion of the maxilla or excessive protrusion of the mandible, or is it both? Well, these anterior teeth look a little retroclined. it's possible that that's what she looked like in the beginning. She definitely most likely had a class 2 bite, and that's why they pulled these teeth out. So maybe she was class 2 div 2 to begin with, and that's the natural inclination of her teeth. But we can come up with the potential conclusion that these teeth are retroclined based on the fact that she had a Boylan bite, and that anterior position of the mandible caused a retrusive force on the maxilla. So for every force is an equal and opposite reaction or reactive force. You can imagine that the mandible wants to go back to its normal position. It's going to pull that way on the maxilla. So theory number one is these teeth are retroclined because of that fact. And if that's true, then that would mean that as her jaw closes on its normal trajectory, they're in the way, causing a posterior open bite. So that's theory number one. Theory number two is her mandible is far forward, and because of the chronic protrusion of the mandible, her condyle, which we'll take a look at in a moment, is actually anteriorized to a degree. I don't know if I've ever seen that, but that's something that necessitates the use of a CAT scan to look inside the joint. So that would be theory number two, and then theory number three is a combination of the two of those. So I'd asked for the CAT scan, which you provided right here. I have access to it. Looking at the joint, I don't really see a whole lot. So let me just kind of walk through when I look at a joint, what am I looking for? This particular software allows us to look at the joint specifically. Here's the joint from the coronal view, and I'm kind of panning through in the sagittal view. First things first, is it in the disc space in its proper orientation to the eminentia? The disc looks like it's properly placed. You don't always see the disc here, and it's hard to confirm that's the disc. An MRI is much better at discerning where the disc is in the joint space. But we can just, this looks normal to me based upon looking at many CAT scans of the joint. There's obviously some beaking here. We see the bird beaking that we learned in dental school. Can mean that there's flattening of the condyle, but this doesn't look severe for a patient. I forget how old she is, but she's 65 to 70, somewhere in there. This doesn't look overly pathologic for somebody of her age. We do see some subchondral cysts here, these radiolucencies that sit underneath the cortical border. Sometimes indicate chronic inflammation of the jaw joint. Subchondral cysts is the term given to them. We also see loss of the cortication here, which is the first sign of chronic inflammation of the joint. But that's just in this one view. As we come around here, we see, maybe that one here, not so much. Just to give you some insight on a scale of 1 to 10, as far as inflammation goes, I would give this a 5. Without pain or other signs and symptoms, I don't know if we would necessarily treat this. One way to treat these is actually to give the patient a mandibular advancement device or a pivot appliance, something that brings their jaw down and forward. It gets them away from the inflammation inside the joint. There could be a case for some arthrocentesis where the oral surgeon will flush out the jaw joint if there's any chronic inflammation. Doppler and JVA are other tools that we can use to assess whether this is a problem or not. But this patient doesn't have any symptoms of the joint, like you said. So I don't know if we're going to do anything about that. Looking on the left side, I do see somewhat of a distalized condyle in the compartment. So there's the ear canal. There's a nerve that runs through there, the quarter tympani nerve, which, if it gets pinched either from mechanical pinching or inflammation of that nerve, that's where patients get tinnitus. So tinnitus and feeling of water in the ears is often a sign of inflammation inside the condyle, in great part because of the nerves that travel through here that give sensory information to the brain are affected by things going on with the joint itself. So yes, teeth can cause ear problems, not directly per se, but the sensation of such. So this condyle here, subchondral cyst in the posterior part of the condyle, that could be rubbing up against the posterior compartment without any symptoms, clicking, popping, tinnitus, fullness of the ear. I don't know if we're going to do a whole lot. The important point here is she's not forward. So if we go back to this, if theory number 2 was correct, that the mandible was forward, we would have to surmise that we would see this condyle down and forward. Maybe this side is down. If you look at the space here, to me, this looks more normal here. Just to make sure that I'm in the proper area, looking at the head of the condyle here. Just make sure we're in the same part of the condyle. So let's bring this over so that we're comparing apples to apples. That there is probably more a manifestation of the fact that she's not closing all the way because her anterior teeth are in the way. So what I learned from this is I don't think it's so much a problem of her mandible is so far forward because of chronic protrusion due to the boil and bite mandibular advancement device. So what do we do here? The patient needs to be able to sleep. So if we're going to move the teeth, she's not going to be able to wear her boil and bite. And there is an approach that we can use, which is probably something I'll recommend, where we use Invisalign and we'll procline these teeth to a more normal position until the mandible closes on a normal trajectory. The problem is the spacing that she has on the upper is already a problem. So the spacing is likely to increase as we flare these teeth more. I don't know if the patient at this age is going to be aesthetically driven. With that said, it's something you're going to want to talk about. You can obviously use veneers to close the spaces. You could even increase the size of the primate space and close this as you procline everything. In other words, take the upper 3 to 3, which is 6 through 11, close all the spaces and leave the remnant space after the occlusion is good behind the canine. You can also close this space here. But that would probably be my suggestion. What's interesting here is the distance between the teeth is less on this side than it is on this side, which corresponds to the condyle on the left side being farther away from the superior part of the compartment of the joint. So yeah, interiorize these teeth until we get occlusion. Let the patient know that we don't know how much we're going to be able to solve this with ortho alone. She has an envelope of function requirement, which is based on neuromusculature that we just can't determine until we get to that point. So having the conversation with the patient that this is a potentially easy solution with Invisalign alone, we don't know what the end game is. This might involve some crowning of the posterior teeth in order to close this bite so the patient can chew. My gut tells me we can probably solve this with Invisalign alone, especially if we create more spaces on the upper, maybe some IPR, interproximal reduction on the lower, and get these teeth to come back together like they always did, and then get her an official solid dentist fabricated mandibular advancement device. The last thing I'll say is because she needs to be treated, there's something called the Moses appliance, MOSES. The Moses appliance is a boil and bite that's a mandibular advancement device that's meant to be used during Invisalign therapy. So something to look into as a treatment modality while the patient's in Invisalign. So I hope this helps. Please let me know if you have any further questions. As I know, this is just not a case that the patient's willing to travel to see the specialist based on distance. I would feel very comfortable with your experience in Invisalign doing this. Just keep me posted. All right. Thank you for the case. Take care.